that's been funded by the Informatics Technology for Cancer Research, or ITCR, from the National Cancer Institute. And the overall purpose of GARDE is it's basically a open source population health platform that allows us to identify individuals who might be eligible for genetic testing of hereditary cancer syndromes. And we also have the ability to use digital health tools to reach out, educate, and offer patients access to testing. So these are our GARDE collaborators from University of Utah, and MUSC is one of the sites with Caitlin, and Cornell and Columbia also collaborators in this project. So the overall motivation is there are estimates that we have about 2 million individuals in the United States who are at elevated risk for hereditary cancer, and they might carry some pathogenic mutation that drastically increases the risk for developing cancer through their lifetime. Unfortunately, over 85% of those individuals carrying pathogenic mutations are identified only after they have already developed cancer. So it's a tremendous missed opportunity for cancer prevention in implementing tailored, individualized cancer screening and detection strategies for these patients. In fact, we have a number of evidence-based guidelines, national guidelines, NCCN, U.S. Preventive Services Task Force, and they consistently recommend risk-stratified screening informed by genetic testing based on family history. So the GARDE project, and we are on the second phase of the project. In the first 5 years of the project, we enabled this platform, and it has 3 main points. So number one, we leverage cancer family history that's already available in the EHR. It's not perfect, not complete, but we found that it's sufficient to identify a large number of people who might benefit from genetic testing. So we don't rely on primary care, for example, having to improve collection of family history, although that would be great. And then we have implemented a number of algorithms trying different options, but they basically apply NCCN criteria for family history-based genetic testing of hereditary cancer syndromes. And then we also created a chatbot platform that includes an authoring tool for patient outreach, education, and access to testing. And we'll talk a little bit about each of these in a minute. The GARDE platform supported the BRIDGE trial, which was funded by the Cancer Moonshot program. The trial has ended, and the primary outcomes paper has just been published. It was conducted at University of Utah Health and NYU. So I'm going to go over the results also. This is the main GARDE architecture paper. It's a more technical paper for those of you who might be interested in the details. I will just go briefly over the architecture so you can have an idea of how it works. It has 3 main components. So on the left, the OpenCDS is a clinical decision support web service that's independent from any electronic health record system. It runs outside the EHR and pulls data from the EHR, runs analyses and for each patient and determines the outcomes. Population coordinator orchestrates the data move between EHR and OpenCDS back and forth. And then we have EHR data as the main source, although we are using other sources as well. So following the data flow, step number 1, we identify the screening population. Most often that consists of patients who have been seen in primary care at a certain healthcare system in the last X number of years. We usually use 3 years. We pull data from for those patients from the electronic health record using the HL7 FHIR standard. That's a national standard that's required for EHR certification. And we send the data in bulk to OpenCDS using the CDS hook standard. That's another national health IT standard for clinical decision support. And we receive all the evaluation is done in bulk and efficiently. And the conclusions are sent back to the population coordinator, which writes the data back into the population registry of the EHR. You know, EHR systems oftentimes have functionality that supports population registries. In this case, we create a registry for hereditary cancer syndromes. And in the bridge trial, we had a genetic counseling assistant being the driver of that registry and using native EHR functionality to manage patient outreach and testing. This is just to give an idea. It's a small subset of the rules we have implemented in GARDE, adapted from NCCN guidelines. These are for breast cancer. And the point here is just to show that for a primary care physician, these can get fairly complicated and the number of rules is large. So for a primary care provider who has very little time in appointments and with many competing priorities, it's very difficult to implement genetic testing. But this is the paper for the main outcomes of the bridge trial. And I'm going to go over first how the workflow for the trial, the different interventions, and then results. So first, again, we run GARDE against EHR family history data. At University of Utah Health or NYU, we had the screening population, primary care population, was about 500,000 individuals. Of those, using GARDE, 5% met testing criteria for hereditary breast, ovarian, or colorectal cancer. So that total between the two institutions, about 22,000 people. 3,000 of those were randomly selected to be enrolled in the trial. It's a pragmatic trial, so we had a waiver of consent. Patients were randomized into two arms. One was an enhanced standard of care, which consisted of genetic counseling appointments for every single patient who was identified, in the chatbot arm, which was automated approach for outreach, education, and access to testing. This shows a screenshot in Epic of the population registry that we created. So all the data shown on the screen for the patients in the list that's shown here are identified through GARDE. Normally, you would have a number of patients. This is just a test patient. Number two here, there's an ability to filter patients. You could filter, for example, based on the patient's provider and conduct outreach provider by provider. Number three, you can track the status of outreach when a message was sent to patients. We used the patient portal MyChart to send messages. Four, some details about the patient's clinical data, including here on the right side, the reason why the patient met criteria. Here, it's a little small, but I'm going to read. This specific patient had a first or second degree relative with ovarian cancer, and that's why this patient met criteria. Number four, yes, the details. And five, here we have the ability to select a number of patients, click that button, and it automatically sends outreach messages via MyChart to those patients. This is the workflow in the intervention arm with the chatbot for pretest. So for patients who meet criteria and are randomized into this arm, patients receive a portal message explaining why they are being contacted. It includes a personalized chatbot link that they can click and launches the chatbot on the web. It could be on the phone or a personal computer. They go through the pretest chatbot, and at the end, they have the opportunity to decide whether or not they want to get tested. If they like to get tested, they receive the test, a kit at home. It's a saliva kit. They collect the sample, send to the lab, and the results get back. Genetic counseling assistant enters the result in the EHR and documents that as an encounter with the chatbot transcript and also the patient's decision to test. All of those get documented in the electronic health record. These are the main topics that are covered in the chatbot education. It's a scripted chatbot, so the content was handwritten by health communication experts, and the PI in the project was Kim Kaffings, my collaborator. And so starts with the patient portal message here. You see the link, click here to receive more information. They can launch the chatbot from there. This is a snapshot of how the chatbot looks like. You see little dialogue. So the content builds little by little, so patients can control the pace of how quickly they want to read. And there are some pauses once in a while. Patients also have the ability to control the level of detail they would like to see. If they're satisfied with the amount of detail they receive, they can move on. Otherwise, they can ask for, can you explain in more details, or can you explain in simpler words? Or they have also the option to watch a video. So at the very end, at the bottom, here's the offer to proceed with genetic testing. If they click yes, again, they will receive a kit at home. If they say, I'm not sure yet, they'll receive a call from the genetic counseling assistant to discuss. We also have a post-test workflow with a chatbot for delivery of results. And so once the results are back, genetic counselor reviews the results. If the test is positive, patients will have a usual care genetic counseling appointment. If the result is negative, then the patients receive another similar patient portal message with a chatbot link, and then they can look, try to understand the implications of that result in this post-test chatbot. So there's no need for a genetic counseling appointment. So back to the study design, again, we had that randomization between standard of care with genetic counseling appointments compared with automated chatbot. We had two primary outcomes. The first one was completion of pre-test education, being genetic counseling on the standard of care arm and the pre-test chatbot on the chatbot arm. The trial was designed to test equivalency, and for this outcome, we found the outcome to be equivalent. So not significant, 24% completed pretest genetic counseling, and 26% completed the chat. The other outcome was genetic testing uptake. And as with pretest education, there was not a significant difference. Those two arms were equivalent, but the chatbot intervention is largely automated, especially the pretest education, which can take a lot of genetic counseling time. So a much more scalable approach for implementation, wide implementation of genetic testing. So we're now started our second year of the GARDE2 project, and the primary ultimate goal is really to try to help disseminate this platform and help disseminate the benefits of what was demonstrated in the BRIDGE trial, and also help cancer researchers test other kinds of interventions, implementation strategies, other study designs, and other domains as well. So the first aim is to enhance the platform based on these iterative pilots at new GARDE sites. So we have GARDE being implemented at MUSC and Cornell. I'm going to show some numbers in a minute. The second one is an important component of this, understanding how much it costs to implement GARDE and to operate GARDE, either on a clinical operational setting or a research project. So we're doing micro cost analysis of IT personnel involved, how much does it cost to host the software, the clinical personnel especially needed to drive a population-based program like this, and it's largely a genetic counseling effort. And third, we have already started on this aim as well, is broad dissemination to other sites. We have a couple of new collaborators. For example, Ohio State already has GARDE also implemented, and we're working with University of Florida and Nevada. So a few numbers in terms of new implementations. We have Utah and NYU, but now also MUSC and Cornell. And you see that the numbers are similar between 4 and 6, 7% of individuals meeting criteria for testing. Cornell is a little higher because the initial analysis was done at a subset of clinics where patients have higher hereditary risk. Other enhancements, we are currently collaborating with UT Houston on, so far we have primarily relied on structured data to extract family history from the EHR. So EHRs have a section dedicated to the collection of family history that's usually completed by patients at home in pre-visit questionnaires or medical assistants during the patient intake. But providers oftentimes, they can write family history within the notes. That information gets buried in the notes. And there are studies showing that there's actually more family history information in the notes than in the structured section. So people have tried to use a number of different approaches to extract that kind of information using natural language processing. But now we have opportunities with large language models like OpenAI, GPT, to try to extract family history in a way that's scalable and generalizable. So this is ongoing. We mentioned the open source chatbot platform. So it includes an authoring tool that allows folks without programming knowledge to create their own chatbots for different domains, for their own institution, and to create new interventions as well. The authoring tool has integration with large language models, both GPT-4 and Llama via API. So you can create scripted chatbot where, for example, the foundational content can be scripted, and that way you ensure consistency, you ensure accuracy, but still you could allow patients to ask open-ended questions at certain points in the script, and those would be redirected via API to GPT-4 or Llama, and the responses come back to the chatbot, so patients can continue the conversation within the same user interface without having to go to, for example, OpenAI's ChatGPT user interface. We have also implemented some functionality to address health disparities. There's data showing that in populations of low socioeconomic status, 25% do not have a smartphone with access to broadband internet. So we created the ability to deliver chatbot content via text messaging, which has a much higher reach. About 97, 98% of the population in the US with low socioeconomic status have a phone that at least can do text messaging. And we also adapted the GARDE infrastructure to support a number of pragmatic trials for different domains related to cancer prevention, but also in other areas like COVID-19 testing. And I'm going to talk about one of these, which has been completed about a year ago. So most of these pragmatic trials are being done in Utah across a number of 13 community health centers they're safety net, federally qualified health centers. And the stars on the map are clinics. So we have 54 clinics from 13 independent community health centers. So one example of a trial we have done with these centers was Scale Up 2. The goal was to deliver at-home COVID-19 testing to patients' homes over the mail. And we used a number of digital health interventions and patient navigation for that. So it was a 2x2x2 factorial design where we had 3 factors. The first factor was the modality of digital health delivery. So a very simple text message offering access to COVID testing. All they had to do was reply yes or no. And a more sophisticated chatbot, similar to the Bridge chatbot, that provided education on testing, why it's important to get tested, what are the benefits, what happens if I test positive, and so forth. We also, down below here, we had two frequencies of delivery offering access to testing every 10 days compared to every 30 days. Motivation for testing can change because people may have symptoms, exposure, so they may have reasons to get tested. So we thought that having repeated offers would be important. And last, patients were randomized to have no access to patient navigation versus having the ability to request to speak with a patient navigator. So all they had to do was reply person to a text message, and a patient navigator would call them. So that resulted into 8 study arms that are shown on the table. This is the text messaging intervention. Starts with, they're sent on behalf of the patient's clinic. So we pull data from the EHRs from those 13 healthcare systems. They all use different EHRs, and they're independent. So it was a fair amount of work. But it starts with the clinic, and the offer that we have free COVID-19 test kits. And if they reply yes, we confirm the address that's recorded in the patient's electronic health record. If they confirm that the address is right, they'll receive the kit within 24 hours over mail. If they reply no to the address, then they have a chance to correct the address. In this example, this was a patient randomized to the patient navigation arm. So you see highlighted in yellow, they can reply person, and a patient navigator would call them. Few screenshots of the chatbot. Starts slightly similar. So right off the bat, they can say, yes, I would like to receive a test, but they can also look at information about testing. So we did some studies, some user-centered design with target users, and those are the main topics that folks were interested in. Interestingly, at that time of the pandemic, the main reason for not pursuing testing, we found, was that patients thought that because they were vaccinated or had already had COVID, they didn't need to test anymore. So, and many people did not know that they might benefit from treatment, and treatment was available without cost from their community health centers. So the last screenshot shows, all they had to do, if they wanted a test, they can click send me a free at-home test. It would confirm their address, and just like in the chatbot intervention. So here's the results. We have the paper under review. This approach, population-based approach, I think one of the benefits of it is the scalability. So you see the sample size for this trial was over 33,000 patients. Again, a pragmatic trial with waiver of consent, and every adult patient who had received care at a community health center was eligible. In terms of study outcomes, first looking at chatbot versus text messaging comparison. Interestingly, and a little unexpectedly, the text messaging intervention was, those assigned to the text messaging intervention was 3 times more likely to request a test than those in the chatbot arm. It's possible that at this stage in the pandemic, people did not need much education about testing. Either they were motivated to test, or education wouldn't make much of a difference. Also, the chatbot required a few additional steps. They had to click on a link. We think that might have been a big barrier. Folks may be concerned about clicking on a hyperlink on a text message. And they had a couple more steps, about 3 more steps, until they could get to the point where they could click send me a test compared to the text message. In terms of frequency, as expected, patients randomized to receive their intervention every 10 days were more likely to request a test than 30 days, although they were also slightly more likely to opt out from the study by replying stop to a message. And last, also unexpectedly, not only patient navigation wasn't effective, it was less effective than individuals randomized to not being able to request patient navigation. It's hard to interpret this, but it's possible that by seeing that there was the chance that somebody could call them may have reduced the motivation to engage with the system. It's possible patients didn't want to receive a call, and even though they wouldn't unless they requested. And last, again, about patient navigation, only 10 patients out of 1,000 randomized to patient navigation replied person requesting patient navigation. So that at least for this trial, patient navigation was not effective. We found different results in other trials, but again, this is a little different. COVID is different than other cases like cancer screening. Here are other health equity trials, all using the GARDE platform. Completed, we have QuitSmart was one of the first trials we worked on with the community health centers with a sample size of 12,000. The goal here was to connect patients who use tobacco to the tobacco quit line using largely text messaging and also an EHR intervention at the point of care that allowed medical assistants to send an electronic referral to the quit line for patients. We have 2 ongoing trials. Beat Pain is getting to the last year of recruitment. It offers patient access to telehealth-based chronic low back pain management, which includes 2 modalities. One is coping skills for pain, and the other one is physical therapy via telehealth. And the ways to connect to this service include providers being able to send an electronic referral to the telehealth group that's housed at University of Utah, and also text messaging. So patients who have an appointment with chronic low back pain receive a text message offering access to the telehealth service. REI Utah is another tobacco cessation trial, but focused on patients who live in areas affected by persistent poverty. And it's a bundled intervention, so it addresses tobacco cessation by connecting to the quit line, but at the time, also assessing social needs and helping connect patients with social services. We have 2 also upcoming trials that got funded recently. Smart Life is focused on connecting patients to evidence-based weight loss programs and bundled also with social needs. And these are all online programs. LungSmart is a factorial trial as well, similar to Scale Up. And the goal is to assess patients' eligibility for lung cancer screening. So that's one stage of the trial. And for those who are eligible, we try to connect them to a central hub where a registered nurse provides shared decision-making for lung cancer screening. And patients who decide to complete lung cancer screening, they also are randomized to interventions to help them complete the appointment. So those are will be launched within 6 months or so. So in summary, GARDE is an open source population health platform, is available for collaborators who would like to try to use it for their own trials, for their own research. It's basically 2 main components. We have the population analytic algorithm, so you can have a number of algorithms that, any kind of algorithm that identifies individuals who are eligible for any kind of healthcare service, generally, preventive healthcare services, coupled with digital health tools, text messaging, and chatbot for patient outreach, education, and access to services. The primary focus has been on genetic testing of hereditary cancer syndromes, but it happened along the way that we received funding and we had collaborators in health equity that, so GARDE has been supported those other trials as well. And we are interested in collaborating with new sites. We're funded, that's the primary purpose of the funding we have now on the GARDE project, is to help disseminate the platform. Thank you.
So thank you. That was great. Josh Lipschutz from MUSC. I had a question about the hereditary cancer screening. So especially the post when you have the genetic counselors, you're going to get a lot of variance of undetermined significance. So it's hard to say yes, no, especially if you don't have child and parent data to look at. So how did they sort that out?
Yeah, for VUS, if I'm not mistaken, the two sites handle those in a slightly different way. And I can't remember which one, but I think one of them, the VUS, were returned along with the chatbot, just like they handle the negative results. And patients always had the ability to call and request an appointment. And the other side, VUS, was handled just like positive results. Patients had to have a genetic counseling appointment.
Thank you.
Hello, I'm Kate Saylor from Geisinger. I'm curious about your thoughts on when people have systematically worse family history records and electronic health records. So from a health equity perspective, people who move a lot or immigrants or people without health insurance, they're not going to have that data. And so they might not be captured in these eligibility criteria.
Excellent question. We have done studies looking at disparities in family history documentation in the EHR and also disparities in the identification of individuals who are eligible for testing. And you're right on the mark. We found major disparities across demographic groups, starting with family history. So as you would expect, several groups are less likely to have comprehensive family history or any family history documentation at all, and also more complete family history. We found that, for example, individuals who self-report as white were more likely to have data such as age of onset or who's the relative who had breast cancer. So it's not only less family history, but also less complete. And that led to disparities in identification. We found that University of Utah Health, patients self-identifying as white were twice as likely to be identified as meeting testing criteria than any other group. We tried different algorithms, see if we can squeeze the EHR as much as we can, from free text, unstructured data. We also looked at the idea of a partial match algorithm where patients would meet partial criteria if they have a family member with cancer, but we don't know the age of onset. And those approaches did increase the identification rate about uniformly across demographic groups. So that was great. The partial match algorithm, for example, increased by fourfold the number of individuals meeting partial criteria, but the disparities persisted. So it's a difficult problem that probably requires deliberate methods to collecting family history from patients that may not, without requiring a patient appointment. I think it's important because a lot of these may have to do with lower healthcare utilization, not having a primary care provider, not having annual visits where family history is more often collected.
Yeah, hi, my name is Kim Foss. I'm a genetic counselor from UNC. Not surprising, I have questions about the genetic counseling. So I'm curious, for the arm that was randomized to genetic counseling, did the genetic counselors find that they were able to clarify the family history? So oftentimes, we hear my aunt had ovarian cancer and then upon further investigation, it was cervical cancer. Or, someone talks about a cousin and when we take a family history, we find it was a second cousin, third cousin, more distant relative. So I'm just curious, were there any I want to be friends with chatbots. I think that they are wonderful, but I'm just curious about, was there looking at the two arms and did the arm that got genetic counseling, was there further evidence that they were able to clarify family history and provide a more accurate risk assessment than a chatbot? Number one, did the chatbot clarify the family history? And then number two, were the genetic counseling arms able to provide a more comprehensive assessment than the chatbot arm?
Yeah, so excellent question. The chatbot, so all patients who decided to get tested in the chatbot arm would still receive a quick phone call from a genetic counseling assistant to confirm the family history, confirm if they really wanted to get tested, and to talk about insurance. So those are usually brief phone calls. And in the trial, in the BRIDGE trial, the situations where the family history was incorrect was extremely rare. It happened when, just a handful of cases. In most of those, one example was when, the familial relationships were, the patient was adopted. And so that was one case. And there were, I think, two other cases between NYU and University of Utah. We have been debating whether that step of that phone call is necessary in the genetic counseling programs at the two institutions believe that it may not be necessary as long as the chatbot does the confirmation. So, but those are interesting research questions. We don't know yet if it would be possible to scale that and let the chatbot confirm the family history.
Hello, I'm Sue Van Kirk, a family nurse practitioner, and also recently finished a PhD program in health services research here at MUSC. My question was about kind of fatigue of texting and chatbots, and so I was wondering about you had that option to turn it off, and I was wondering if you kind of track not only who was just getting the testing, but was it clear that it was even read or responded to? And was there a mechanism too, if people did turn it off, to kind of reconnect with them at a future time?
Yeah, good question. So that is certainly that's a huge issue, and something that's difficult, especially if you have multiple trials competing for patients' attention, and also the healthcare system is sending messages to patients as well, right? They're more and more. Our healthcare system is starting to use text messaging for a number of things, and the patient portal they use it for all sorts of things, from billing to confirming appointments and test results. So that is certainly an issue, and that it's an important research question about timing of text messages. Do you bundle all of them into one? You are overdue for your mammogram, your colorectal cancer screening, diabetes screening. Send one message bundled with all those reminders, or no, you should space them out and try to avoid fatigue. The other consideration is, although we have seen over and over across these trials that if repeated offers are significant in improving the uptake. And in one study we found, for a connection with diabetes prevention program, one offer compared to multiple offers, patients were 5 times more likely to connect to the service. But at the same time, we see an increased number of opt-outs as you increase the repeated offer. So in one trial now, we're also doing a dose response. There's a dose response designed to try to figure out the optimal number of responses. In terms of, so all these messages by regulation, federal regulation, you are required to include an option for patients to opt out, and it has to be the word stop on a text message. So patient replies stop, they will be opting out from that number at the carrier level. So and it also on our system, patients will stop receiving messages. We have not thought about the idea of letting patients, I want to pause, for now, don't want to receive messages, but if they change their mind in the future, or want different ways of being connected, we haven't thought about that, but that's a great idea.
Are you going to follow up the cohorts to see if how many cancers are discovered, or even a decrease in mortality with your study?
Yeah, that's a great point. The bridge trial has ended, the funding has ended, so unfortunately, there's not a plan to continue to look at that. But it would, future studies, I think, should look at the, interventions to help implement high-risk management for those patients. What happens that's part of standard of care. Patients who tested positive at the two institutions are referred to a high-risk clinic at the Cancer Center Institute at one of the two institutions. But unfortunately, we don't have in the trial ways to follow up with those patients. I think there should be studies looking at that, interventions to make sure that you help patients adhere to high-risk cancer management and follow up on outcomes.
I think if we